So the new topic is metabolic syndrome, previously known as Syndrome X. National Cholesterol Education Program, Adult Treatment Panel, and International Diabetes Federation have defined criteria for metabolic syndrome, where it is diagnosed as if the patient has three or more of the following characteristics. The risk factors, for example, firstly is waist circumference more than 94 centimeter, weight a woman more than 80 centimeter, triglyceride more than 1.7 millimole per liter, HDL less than 1, and BP more than 130 by 85, or active treatment of hypertension, or fasting glucose more than 5.6, or previously diagnosed type 2 diabetes. So these together is metabolic syndrome. IDF, so we have to remember the criteria, okay? IDF criteria, having increased waist circumference for plus more than two risk factors. Well, this explains three of the factors for diagnosis. Other associated factors can include hyperuricemia, non-alcoholic fatty liver disease, polycystic ovarian syndrome. Management is weight reduction. Increased physical activity. Regular physical activity will decrease LDL, VLDL, and BP and insulin resistance, and can have beneficial effects on cardiovascular function. LDL reduction is also important. Treat hypertension, aspirin, and treatments to decrease TGL, triglyceride, HDL, and have also been shown to reduce coronary heart disease risk. Other lifestyle factors in addition to physical activity must be addressed: moderation in alcohol intake and cessation of smoking and monounsaturated fat in the diet. All these have to be applied. Obesity physiology, obesity hormones, leptin decreases appetite, ghrelin, growl of stomach increases appetite. You have to remember like that. And increased thyroxine is increased appetite, but not in obese patient. Leptin is thought to play a key role in the regulation of the body weight. It's produced by the adipose tissue and acts on satiety centers in the hypothalamus to decrease appetite. It's produced by the adipose tissue, so it decreases appetite. More adipose tissues results in high leptin levels. Leptin stimulates the release of melanocyte stimulating hormone and corticotrophin releasing hormone. Low levels of leptin stimulates the release of neuropeptide Y. Ghrelin, whereas leptin induces satiety, ghrelin stimulates hunger. It's produced mainly by the fundus of the stomach and pancreas. Ghrelin levels increase before meals and decrease after meals. Increase before meals and decrease after meals. Okay. Next would be obesity. BMI normal is 18 to 25. Overweight 26 to 30, and obese 31 35, obese 230 to 40, morbidly obese more than 40. So it should be here. Therapeutic options: the management of obesity consists of a stepwise approach: conservative diet, exercise, medical, surgical. Orlistat is a pancreatic lipase inhibitor used in the management of obesity. Adverse effects include fecal urgency or incontinence and flatulence. It should only be prescribed as a part of an overall plan for managing obesity in adults who have BM more than 28 and risk factors, or BMI more than 30. Continued weight loss 5% at 3 months. Orlistat is normally used for less than 1 year. Okay, pancreatic lipase inhibitor. Okay, and co-prescribing orlistat with other weight reduction drugs is not recommended. Naltrexone, bupropion shows with lifestyle is more effective than lifestyle alone. And sibutramine, withdrawn January 2010 due to increased risk of cardiovascular events. Centrally acting appetite suppressant, inhibits uptake of serotonin and noradrenaline at the hypothalamic sites at regular food intake. Adverse effects include hypertension, constipation, headache, dry mouth, insomnia, and anorexia. Rimonabant, a specific CB1 cannabinoid receptor antagonist, was withdrawn in October. Okay, because of side effects. Bariatric surgery, consider surgery BMI is more than 40 or BMI more than 35 with other significant diseases like type 2 diabetes and hypertension that could be improved if lost weight. All appropriate non-surgical measures have failed to achieve or maintain adequate clinically beneficial weight loss for at least 6 months. They will receive intensive specialist management and commit to long-term follow-up. Fit for anesthesia and surgery has to be there. Consider surgery as first-line option for adults with a BMI more than 50 in whom surgical intervention is considered appropriate. Consider orlistat before surgery if the waiting is too long. Okay, so that's what I need to do. Try out everything, and if everything fails, that's when you start thinking about the surgery. Okay. Biliopancreatic diversion or with duodenal switch is a primarily malabsorptive procedure and reserved for patients who are obese. So these are like types of surgery. Types of bariatric surgery. There are like three types: primarily restrictive, laparoscopic adjustable gastric banding or sleeve gastrectomy. Then primarily malabsorptive. Classic biliopancreatic diversion has now largely been replaced by biliopancreatic diversion with duodenal switch. Mixed Roux-en-Y gastric bypass surgery. Okay, which operation to do? Uh, Laparoscopic adjustable gastric banding or LAGB produces less weight loss than malabsorptive or mixed procedures, but it has fewer complications. So it is normally the first line intervention in patients with BMI of 30 to 39. Okay. Patients with a BMI of more than 40 may be considered for a gastric bypass. So it will produce less weight loss than malabsorptive or mixed procedures, and it has a fewer complications. So normally the first one. So this is the first one you think about: laparoscopic adjustable gastric banding. So it's first line intervention for a patient with BMI of 30 to 39. Patients with a BMI of more than 40 may be considered for bypass gastric bypass, or sleeve gastrectomy. The latter may be done as a sole procedure or as an initial procedure prior to bypass. Primarily malabsorptive procedures are usually reserved for very obese patients. Okay, so that's classic biliopancreatic diversion. That's for a very obese patient. Okay, BMI more than 60. So just keep an eye on this. This is 1, and this is 2. 1 and 2. Glycemic index. Okay, describes the capacity of food to raise blood glucose in normal glucose tolerant individuals. Food with a high GI glycemic index may be associated with increased risk of obesity and postprandial hyperglycemia. Associated with risk, such foods may also increase the risk of type 2 diabetes mellitus. So, what are the high glycemic index food? Like white rice, baked potatoes, white bread, cornflakes, Rice Krispies, watermelon, croissants, extruded breakfast cereals, straight glucose. Medium glycemic index: couscous, boiled new potato, digestive biscuits, basmati rice, whole wheat products, sweet potato, table sugar, most white rice, jasmine. Low GI fruit and vegetables, except potatoes, watermelons, peanuts, grainy breads, pasta, legumes, milk products, extremely low in carbohydrates. Fish, eggs, meat, some cheese, nuts, cooking oil, brown rice. So yeah, all these can be taken. Okay, hyperlipidemia. This one's not really needed to master. Take a look at it. Like what really increases, what decreases. Familial hypercholesterolemia is the one with very high CVD risk, high TC and TG for all of them. And predominant hyper TG is polygenic, or this not very much. Pancreatitis versus more, and mixed hyperlipidemia. This is the one. So high risk lipid profile includes total cholesterol more than 4 and LDL more than 2. So TG more than 4.5, and any patient with type 2 diabetes mellitus should receive statin. If they have other risk factors: smoking, hypertension, and high risk lipid profile. Familial hypercholesterolemia is an autosomal dominant condition of chromosome 19 that is thought to affect around 1 in 500 people. It results in high levels of LDL, which, if untreated, may cause early cardiovascular disease. Familial hypercholesterolemia is caused by mutations in the hepatic proteins involved in clearance of LDL from the circulation. And FH is defined in the WHO classification as a type 2A hyperlipidemia. Tendon xanthomata are virtually diagnostic of heterozygous familial hypercholesterolemia and occurs in 70% of affected individuals after the age of 20 years. Xanthelasma and premature corneal arcus are commonly found, but are less common specific signs. Increased cholesterol that characterizes heterozygous FH leads to increased In more than 50% risk of coronary heart disease in men by the age of 50 years and at least 30% in women at the age of 60 years. Homozygous familial hypercholesterolemia is exceedingly rare. Most patients will die in their teenage years from a MI. It's very important. Okay. Clinical diagnosis of FH is now based on Simon-Broom criteria. Um, Total cholesterol, adult more than 7.5 and child more than 6.7, and LDL more than 4.9, more than 4. Definitive diagnosis levels as per table above either. Tendon xanthomata, evidence of these signs in first or second degree relative or DNA evidence of LDL receptor mutation. Possible diagnosis levels as per table above plus either. Family history of MI age less than 50 in second degree relative or age less than 60 in first degree. Family history of total cholesterol. So we need to know about these levels in like mg per dl, because that's what we see usually. Total cholesterol is usually more than 9 in familial hypercholesterolemia, and FH who have not developed CVD have a mortality rate at least 7 times more than the general population. It's present in the 5 to 10% of individuals who develop CHD. It's important that all first degree relatives of premature CHD are screened. The use of cerebrovascular disease, cardiovascular disease, risk estimation using standard tables is not appropriate in FH. Referral to for a specialist lipid clinic is usually required. First treatment is statin. There is evidence that increased statin doses daily may reverse intimal thickening in FH. Start at 40 mg, then increase to 80 to achieve target. Aim for at least 50% reduction in LDL-C concentration from the baseline measurement. Ezetimibe is recommended as monotherapy or add-on to statin. If target is not achieved, specialists may consider evolocumab. Therapy for a child should usually be considered by the age of 10. And first degree relative have 50% reduction, 50% risk, and should therefore be avoided screening. Statins should be discontinued in women 3 months before conception, and due to risk of congenital defects before conception. Okay, secondary hyperlipidemia causes can be hypercholesterolemia. Drugs like diuretics, cyclosporine, androgen, antiretroviral. Hypothyroidism can be a cause of this. Pregnancy, cholestatic liver disease, less common nephrotic syndrome, anorexia nervosa, porphyria, hyperparathyroidism. Hyper-TG is diabetes type 1 and 2. Obesity, alcohol, chronic liver failure, drugs, thiazide, non-selective beta blocker, unopposed estrogen, antiretroviral, glucocorticoid, liver disease, alcohol. All these can be hyper-TG causes. Some drugs like beta blocker. These are actually tough to remember all of them, but like you just need to remember the basic stuffs so that it helps you out in the exam. We're almost near the end of endocrinology. So yeah, management of hyperlipidemia is like predominant hypercholesterolemia. You give statin for sure. Statin plus minus ezetimibe, resin, nicotinate. Mixed hyperlipidemia combination like statin plus fish oil plus fibrate, all these. And predominant hyper-TG give fenofibrate at first, fish oil plus nicotinate. Remnant hyperlipidemia, rare cause of mixed hyperlipidemia, raised cholesterol and TG levels, also known as Frederick type 3 hyperlipidemia, broad B disease, and D is beta lipoproteinemia, associated with APOE2 homozygosity. High incidence of ischemic heart disease and peripheral vascular disease, thought to be caused by impaired removal of IDL from the circulation by the liver. Remnant hyperlipidemia features can be yellow Palmar creases and Palmar xanthoma and tuberous xanthoma, fibrous at the first line. Characteristic xanthomata in hyperlipidemia, you can see here may not be clear in the video. Palmar xanthoma, remnant hyperlipidemia may less commonly be seen in the familial hypercholesterolemia. Prolonged cholestasis, so increase total cholesterol, moderate in TG, moderate increase in TG, decrease HDL levels, serum is not lipemic. Palmar xanthoma, tuberous xanthomata. Xanthoma usually only occur if cholestasis has persisted for more than 3 months. Sometimes fat deposits may involve bone and peripheral nerves. eruptive xanthoma are due to high Tg levels and present as multiple yellow vesicles on surface, elbow and knee. Cause of eruptive xanthoma, hyper Tg, eruptive xanthoma, lipoprotein lipase deficiency. So, and tendon xanthoma, tuberous xanthoma, family hypercholesterolemia, remnant hyperlipidemia. You see this FH. Xanthelasma can also be seen without lipid abnormalities. Management of xanthelasma is surgical excision, topical trichloroacetic acid laser therapy, electrodesiccation. Next topic, in fact, is the last topic for endocrine syndromes and neoplasia. Not much. Carcinoid. Carcinoid is a slow-growing type of neuroendocrine tumor. It's a tumor. Slow-growing type of neuroendocrine tumor originating in the cells of the neuroendocrine system. So, neuroendocrine tumor. So, carcinoid syndrome usually occurs when metastases are present in the liver and release serotonin into the systemic circulation. So, metastases will be present in the liver, and the liver will release serotonin in the system. So, serotonin symptoms are seen. May also occur with lung carcinoid or as mediators are not cleared by the liver. Okay. So, serotonin results in what? Flushing, diarrhea, bronchospasm, hypotension, hypotension, secondary to serotonin release. Right heart valvular stenosis, left heart can be affected in bronchial carcinoid. Okay, ACTH, GHRH may also be secreted, resulting in Cushing syndrome. Okay. Pellagra can rarely develop as dietary tryptophan is diverted to serotonin by the tumor. So, flushing, diarrhea, and bronchospasm. Flushing, diarrhea, bronchospasm, tricuspid stenosis, pellagra, carcinoid with liver mets, diagnosis urinary F5HIAA. So that's what you give. Somatostatin analog octreotide. Diarrhea, cyproheptadine may help. Okay, somatostatin analog like octreotide. You be given, and you have to remember these 5 things for carcinoid syndrome. Okay, next is autoimmune polyendocrinopathy syndrome, Addison's disease. Autoimmune hypoadrenalism is associated with other endocrine deficiency in approximately 10% of the patients. There are 2 distinct types of autoimmune polyendocrinopathy syndrome, with type 2, Smith syndrome, being much more common. So let's do the APS2 common one first. Polygenic inheritance linked to HLA, DR3, DR4. Patients have Addison's disease plus either type 1 diabetes mellitus or hypothyroidism or hypogonadism or celiac disease or myasthenia gravis. So this is APS2 polyendocrinopathy syndrome. So the patient has either with Addison's, along with Addison's disease, the patient also has one of these 5, like type 1 diabetes mellitus or thyroid disease or celiac disease, myasthenia gravis, and APS1. Multiple endocrine deficiency autoimmune candidiasis. It's a very rare autosomal recessive disorder caused by mutation of AIRE1 gene on chromosome 21. Features of APS type 1 are chronic mucocutaneous candidiasis, Addison's disease, and primary hypoparathyroidism. So APS1 is autosomal recessive, and 2 out of 3 are needed. So Addison's disease, and then primary hypoparathyroidism, and chronic mucocutaneous candidiasis. Vitiligo can occur in both types, and primary hypoparathyroidism is usually the first endocrine manifestation of type 1 autoimmune polyendocrinopathy syndrome. Okay, while men, hypoparathyroidism is a common finding. So all this while we have been thinking about we have been saying men. So what is this men? Very important topic. Multiple endocrine neoplasia, autosomal dominant. So men type 1 will have, which is also called Werner syndrome. We have three P's. That's what you need to remember. Parathyroid involvement is there. So hyperparathyroidism due to parathyroid hyperplasia. Pituitary 75%, 70% involvement. Pancreas is also involved 50% of the times, like gastrinoma. Also adrenal, thyroid. But what you need to remember is these three P's: parathyroid, pituitary, pancreas. Men Gen 1 presentation is hypercalcemia. Okay. Men 2A is pheochromocytoma, 95%. Medullary thyroid carcinoma, parathyroid. So femipar, that's it to remember. And this is papipan, femipar, and his femi, I don't know what. 2B, medullary thyroid cancer, pheochromocytoma, marfanoid body habitus, neuroma, and then intestinal polyps, all these. Men to red oncogen, horizontal dominant, 50% being sporadic. Screen their kids in first degree. Red is for red gene, so red oncogen for men 2. Again, let's go through the thing. Like for men 1, it's the three P's: hyperparathyroidism, pituitary involvement, and pancreas involvement. Type 2A is pheochromocytoma, and then medullary thyroid carcinoma, parathyroid involvement. Type 2B is medullary thyroid cancer, same as 2A. Pheochromocytoma, same as 2A. And marfanoid body habitus, neuroma, intestinal polyp. And red oncogen is positive for both men 2 and B. The high incidence of parathyroid tumors and hypercalcemia makes serum calcium a useful indicator of men type 1 suspected individuals. In pheochromocytoma and suspected men 2A, check for medullary cancer, then first, then parathyroid. So the disorders you can see are Cushing's syndrome. You do overnight dexamethasone test. Cushing's versus pseudo-Cushing insulin stress test. Addison's disease short synaptone test. Addison's disease short synaptone test, and pheochromocytoma 24-hour urinary metanephrine, and acromegaly OGTT. All these investigation of choice. That's the end of endocrinology.